So welcome to this session that I chaired with my friend Steve Joniau on high-risk prostate cancer. And I will leave him the first words on this universe of disease.
Well, interestingly, high-risk prostate cancer there's not a real clear definition for this disease state. Actually, several international scientific organizations use different definitions. But let's stick to the EU definition of high-risk prostate cancer. And actually, that's maybe new now here in Madrid. With the new guidelines, high-risk prostate cancer is defined as, according to the D'Amico definition, it's clinical stage T2C, it's PSA over 20, and it's Gleason score 8 to 10. And next to that, that's high-risk localized disease. Next to that, there is another group which is considered high risk, and that is the locally advanced prostate cancers, T3A, T3B, T4, and N+ disease. We know
that altogether it's not a homogeneous group of
absolutely.
Patients, isn't it?
It's a very heterogeneous group of patients, and I think what we need and from a clinical standpoint is a better substratification of these patients. And there is some data which is recently published in the European Urology from a group that we know very well. MPACT is a European multi-center group, clearly shown that the number of high-risk factors which you have jointly together is determining worse and worse prognosis, and this is shown now in MPACT in a surgical series. But there is data, and there is recent data on a very similar risk model in radiation-treated patients, and you see exactly the same correlation. Yeah. So, next to that, I think that imaging and molecular markers will become very, very important in risk, in specific risk substratification. There is new data on that. Unfortunately, or fortunately, but the risk stratification is usually based on the radical prostatectomy specimen. So then the decision for treatment has already been made. And regarding treatment, the standard of care, which has the highest level of evidence, is actually radiation, I think.
If I may, I would at first say that we know, both surgeons and radiation oncologists, that the treatment is needed for those patients.
Yeah, I agree.
We are a little bit understanding now that if you do not treat locally those patients, they will, die probably earlier, and they will risk a lot of local complications. So I think, do you agree that this is at least something we agree upon?
I fully agree. It's absolutely vital to choose in those patients with high-risk prostate cancer who are in well enough condition to choose for active local treatment.
Yeah. And by the way, you are certainly aware that there are randomized clinical trials that have shown that hormones alone for this subgroup of patients is not enough. You have to add some local treatment, which in these trials was radiotherapy, but I guess that this could be mirrored by surgery. So I the first standpoint.
I do agree, and there is good data on natural history of high-risk prostate cancer. Indeed. Those patients have a risk at 10 years of 50-60% of dying from their disease, and you can cut this down to maybe 10-15% if you use local treatment. And either surgery in large retrospective series has shown this, and radiation combined with hormones have shown exactly the same correlation. So yeah, hormones alone should be avoided. And what we see nowadays is up until recently at least, is something that is counterintuitive. Yeah. Low-risk prostate cancer has been treated very, very densely with surgery, with radiation, intermediate risk prostate cancer as well. And then if you look at high-risk prostate cancer groups, you will see that in some of these population-based studies, you see that patients are treated with hormones alone, and which is not understandable. It should be the other way around. I don't say hormones for low risk, but less dense treatment in low-risk prostate cancer maybe implement follow-up active monitoring and intensely treat high-risk prostate.
I guess we now are shifting a little bit from, the idea that only patients with low-risk cancer could be cured and had long survival.
Yeah.
Yes, they have, because they have a very low-risk disease. Independent of what they will receive as treatment, they will have a long survival. And we are shifting to focus on the real population of patients with risk to die for their disease, which is high-risk disease. And of course, Steve is a kind guy, so he's not mentioning that surgery has a big advantage as compared to radiotherapy for those patients. Not Steve.
Well, we are a little bit hampered by the fact that we don't have good prospective data. We don't have any randomized studies comparing surgery versus radiation. There has one started recently, as the SPCG 15 study, which is comparing surgery versus radiation plus hormones. But in fact, yes, if you look at surgically treated patients, and that is something that is in the mind of a lot of urologists still, is that if you operate these patients, they will have a high number of positive margins, positive nodes. You're not curing these patients. They need radiation afterwards. They need hormones afterwards. They have poor quality of life. All these things are not quite correct. If you operate high-risk prostate cancer, you will find in about 40% specimen-confined disease, which is defined as T2, T3A, negative nodes, negative margins. And these patients have exceptionally good outcomes. They have 98% 10-year cancer-specific survival. And patients, they have the same rate of complications. They have really very good quality of life. We have data on that. Will be not published, but will be discussed here at the EAU. And so this surgery is a quite good option for selected patients. I'm not saying it's better than radiation, but we have to start to believe that surgery has a role.
If you agree, I would say that whatever you do to those patients, you have to do that quite at high level of expertise and technology.
I agree.
Unfortunately, as soon as you move again from low risk to high risk patient, whatever you do should be done with high technology and high expertise. Yeah. This is true for surgery, as you said, good lymph node dissection. If you want to keep as low as possible the burden in terms of side effects. But this is also true for radiotherapists. If you want to treat this patient correctly, you probably have to be aware that you have to use up-to-date technology, IMRT, high dose in the prostate, boost with HDR. This also will be discussed here in Madrid. And you have to know how to manage hormones with those patients. Yeah. And we are, little by little, for sure that we were in this idea that we would need long-term hormones for these patients. But as you said, this is not an homogeneous group of patients. No. So I do believe that there is a subset of patients in this high-risk group which do not need such long hormones. And hormones are, we know, impacting on quality of life of those patients. So I guess there is a lot that should be studied in those patients. And do you agree that the old battle between urologists and radiotherapists in order to treat those patients is something which really we can forget now?
We should, yeah. I think you're quite right. We should forget the struggle and the battle. We have to work together. And we have a very important job for the near future is indeed exactly what you say. Don't treat all the high-risk patients with adjuvant radiation. Maybe a subset will need it. Don't treat all the N+ patients with adjuvant hormonal treatment. There are subsets of patients with high-risk features, with positive lymph nodes, who don't need immediate adjuvant treatment. And we will have to try to tease out those groups of patients who need only, well, maybe monotherapy, radiation or surgery, and the patients who need the full Monty, who need surgery, radiation, and hormones in a certain sequence and timing. And this is something that we really need. And I think, again, that markers, that molecular markers, gene expression profiles can help us in teasing out these patients. There is data on that. There will be data here discussed in Madrid. There is data published recently. There are really very good sets which are already available to patients, sets of markers which can really help identifying the real high-risk patients and those who will be doing much better.
So, Steve, I think we agree also that patient, his history, his family should be put really in the center of our efforts. Yeah. This means that we have to better understand what kind of disease he has, and we have to work together. And yes, multidisciplinarity, which is a word that you can, repeat a lot in these years, has its importance exactly for those kind of patients, I guess.
That is quite right, and I think it's implemented already in many countries. Yeah. That a multidisciplinary team is mandatory, but it should be like a natural fact. It should not be an obligation.
Kind of patients, yeah, which are the one, as I can repeat here, that will die for their cancers.
Maybe just one last thing is that we should not forget the patient himself. Indeed. And implement the patient into the decision.
Absolutely.
Which treatment to choose, yeah, for this specific.
And how to evaluate the different options he has in front of him.